Good morning, everyone. My case report is on an infraorbital granuloma with chorioretinal atrophy due to ocular cysticercosis. On introduction, ocular parasitic infections are considered significant cause of ocular pathologies worldwide. The parasitic etiological agent include mainly protozoa, helminths, and ectoparasite. Adult or larval stage of the parasite may reside in human ocular tissues, externally or in the ocular globe. Ocular cysticercosis commonly seen in younger age group with no gender predilection. The parasite reaches the posterior segment of the eye via the high flow choroidal circulation through the short posterior ciliary arteries. The macular region being the thinnest and most vascularized, the larva lodges itself in the subretinal space from where it perforates and enters into the vitreous cavity. In this process, the parasite can cause a retinal detachment, macular hole, or incite an inflammatory response. Now, my case report. A 59-year-old female with the following presenting complaints in the right eye. Her complaints were recurrent painful periorbital swelling, lacrimation, and severe decreased vision. Only hand movement was present. The duration of the disease were about 6 months. The periorbital swelling had a waxing and waning course. On local examination, the visual acuity was finger counting close to face, periorbital swelling and ecchymosis was present, narrowed palpebral aperture, the palpable mass was present in the infraorbital region, the nasolacrimal duct was blocked, there was RAPD present, and anterior chamber was no reaction but vitreous shows mild vitritis. On fundus, there was chorioretinal atrophy with pigmentary changes. There was multiple discrete subretinal whitish lesions. One grayish-white subretinal fibrous tissues like component extending from the optic disc was present, and the features suggestive of combined retinal detachment in the posterior pole with scar tissue formation. Now, UHG B scan was done, and there was an irregular thick-walled cystic lesion with ill-defined internal floating contents in the infraorbital region. Orbital tissue edema was present, vitreous membrane was seen, and there was focal retinal detachment. On laboratory investigation, hemoglobin was 10, and there was mild eosinophilia was present, and there was ESR was high. From going through the patient history, demographic information, and fundus examination, and UHG B scan report, there was an infraorbital mass with chorioretinal atrophy with focal retinal detachment may be due to parasitic etiology is the presumptive diagnosis, which is yet to be confirmed by histopathological examination. Treatment was, the patient was treated with oral antibiotic, oral prednisolone, 1 mg per kg body weight for 1 week and then tapered off. The infraorbital region was explored and a thick wall cystic mass was excised. The follow-up was done 1 monthly. The patient became asymptomatic, but visual prognosis remains unchanged at least at 6 months follow-up. The left eye BCVA was 6/9 and absolutely normal. My histopathological examination was showed that there was eosinophilic infiltration with hooklets and circus suggestive of cysticercosis. Final diagnosis: an infraorbital granuloma with chorioretinal atrophy due to ocular cysticercosis. Discussion: cysticercosis is a preventable cause of blindness. Blindness endemic in India. Parasitic infection caused by cysticercosis cellulosi, which is the larval form of Tinea solium. The extraocular muscle are the commonest type of orbital and adnexal cysticercosis. Superior rectus muscle is most commonly involved. Diagnosis of orbital and adnexal cysticercosis is based on the clinical, serological, and radiological findings. Systemic corticosteroids are used before and after surgical removal of the cyst should be done. Thank you, sir.
Okay, thank you, madam.
Thank you.